Hi everyone. So I had Franco Dombrowski. He's a 71-year-old man who came into my clinic for evaluation of his progressive shortness of breath. So he first noticed his problem 5 to 6 years ago, and it's been progressively getting worse. The shortness of breath is aggravated by cold weather, dust, smoke, and lying down. Breathing fresh air, coughing up his phlegm, and sleeping on 2 to 3 pillows seems to help his symptoms. He can hardly get around anymore due to his shortness of breath. He sometimes has chest pain and dizziness when he coughs, which feels like a sharp stabbing pain under his breastbone. He has seen his PCP for this problem about 6 months ago and was prescribed Advair, which was helping him initially, but it doesn't seem to be working anymore. With his past medical history, overall, he is healthy other than this bout of shortness of breath and coughing that he's been experiencing. No prior hospitalizations or surgeries. He has had normal growth and development. No major injuries. Medications is just the Advair that he's been prescribed for the past 6 months. I don't know the dosage or how many puffs he takes a day. And he occasionally takes aspirin. He's allergic to dust and pollen, and he experiences wheezing when he's exposed. For family history, his father died of heart attack at 72. His mother died of old age at 86 and had arthritis. He has 2 brothers that are overweight, also have breathing problems, but alive. Sister's alive and healthy. He has 2 sons alive and healthy. For his social history, he is married with 2 grown children. He's a corn farmer, has been his whole life, and former Army member. His wife and son say that he has been irritable and uncooperative the last few years. He smokes 2 to 3 packs of cigarettes a day since he was 20 years old, but currently is smoking 2 cigarettes a day, so he's working on quitting. He can't exercise anymore because he is just so short of breath. He told me he has no environmental or occupational hazards, but he's a farmer, so he's exposed to dust, fumes, and chemicals on the daily. He's not on a special diet, but he hasn't had an appetite recently. He does drink occasionally and no illicit drug use. Immunizations, he doesn't have any, so he needs all of them. I'm not sure about his childhood vaccination status either. Moving on to the review systems, his skin was dry, itchy, gets dry and itchy in the winter. He occasionally, moving to the head, he has occasionally has a headache between the eyes when he wakes up at night. This is where he takes his aspirin to help with that pain. With his eyes, he does have some vision loss that's worse at night. Ears, he does experience vertigo and lightheadedness when getting out of bed. This has only been over the past 6 months. Nothing with the nose. The mouth, he does have dryness when he's having to breathe through his mouth to get enough air. And his teeth are stained from smoking. Circulatory, no ankle swelling, edema. He has that sharp stabbing chest pain under his breastbone when he can't breathe or coughs too much. He does have some claudication in the calves and thighs when it's cold or when he's walking out of breath. He does have cramps that dissipate when he's able to catch his breath, cold hands and feet that aren't affected by the season. And then he also has to get up in the middle of the night to breathe, and this has been over the past 5 to 6 years, but really bad in the past 6 months. He does have to sleep with 2 to 3 pillows. He has aropnia. Lips are bluish, and then that gets worse with exercise. For respiratory, he does have intermittent coughing and a productive cough that has green yellow sputum. He says it's about a shot glass amount, and then wheezing during exertion. For gastro, his appetite could be better. General, he's got weakness, anxiety over his inability to breathe. Hasn't had a fever recently. For the physical assessment, just generally speaking, he is a thin 70-year-old white male. He's sitting upright, coughing frequently, 5'7", 125 pounds, so lower BMI. His eyes were found to be normal on the fundoscopic exam. Ears, both were impacted with cerumen. The mouth, lips were bluish, buccal mucosa was slightly cyanotic, moist, without ulcers or nodules. Pharynx is inflamed. With the neck, there was no enlarged lymph nodes, no tenderness, no enlargement of the thyroid. The sternocomastoid and upper trapezius muscles were attended with while he was breathing. For a cardiovascular exam, he did have a single normal S1 sound, and the S2 sound increased with inspiration and decreased with expiration. No murmurs. The lungs were, the sounds were decreased on upper lobes bilaterally. Expiration was prolonged. No rales. And then mid-level, the sounds were decreased bilaterally. There was a small amount of rales and then crackles at the bases. Vocal fremitus is decreased and symmetric. And then palpated respiratory excursion is symmetric. The chest is barrel-shaped with increased ratio of AP to lateral diameter. He uses his accessory muscles with respiration and mild intercostal retraction and tendency to purse-lip breathe. His respiration was regular, 28 breaths per minute. Wheezes are audible with forced expiration and prolonged expiratory time. The abdomen was normal bowel sounds in all four quadrants. Liver dullness was 6 centimeters in the mid-sternal line and 9 centimeters in the right mid-clavicular line. The area dullness descended 3 centimeters on inspiration. Mild tenderness to light palpation. Deep palpation, there was a firm, regular, smooth liver edge that was palpable 1.5 to 2 centimeters below the right costal margin. An overall height of 13 centimeters. And then the spleen was unpalpable. Extremities, there was no heat, tenderness, edema, or soft tissue thickening, but there was muscle atrophy on the thighs. And then he had hyperreflexive. He was hyperreflexive for his patellar reflexes. Vitals, his blood pressure was elevated at 146/80. Heart rate was normal, temperature was normal, respirations were elevated at 28, pulse was normal, oxygen saturation was 89, so that's low. He did have a slight sinus arrhythmia, BMI was low. I then did a spirometry test, which showed a severe obstructive pattern with marked reduction in both FEV1 and FVC. The FEV1 was 0.64, so that's below 0.7. And that was about $100. CBC, I also did a CBC with differential, which was normal. That was $151 approximately. And then I did an EKG, which was found to have right ventricular hypertrophy and pulmonary hypertension. That was about $205. And then the chest x-ray showed barrel chest and lung hyperinflation and rapid tapering of the vascular markings, which are signs of COPD. But no signs of cardiomegaly, and that was about $88. So total for all those tests were $544. I was thinking about doing an exercise test, but he, when I was interviewing him, said he could barely walk from his car to the building, so I declined that. So final diagnosis, I did COPD. So my rationale is that this kind of happened, the onset was later in life. He's a long-term cigarette smoker, progressive shortness of breath, especially while moving. He's wheezing, coughing, has mucus production, reduced exercise tolerance, the increased AP diameter with accessory muscle use and retractions, purse-lip breathing, bluish lips, the cold hands and feet, prolonged expiration on forced exhalation. He has hyperinflation, decreased breath sounds and wheezes at the base of the lungs, depressed diaphragm with limited movement. On chest percussion, he's got the enlarged tender liver. Spirometry was less than 0.7. His low oxygen saturation, and his chest x-ray really was positive for COPD symptoms. My differentials were asthma, so I thought about this one because he did have the wheezing, shortness of breath, allergies to dust and pollen, but there was no family history of asthma. The onset was not early in life, and his symptoms don't vary from day to day. Another differential I had was congested heart failure, which I was thinking, he has a shortness of breath, fatigue, sleeping with pillows, chest pain, dizziness, his inability to exercise. but the chest x-ray didn't show enlarged heart or pulmonary edema. And then my last one was tuberculosis, so he didn't have any fever. He did have sputum though. His CBC was normal. He did have fatigue, weight loss, muscle atrophy, shortness of breath, but his lymph nodes weren't swollen. The chest x-ray didn't show any lung infiltrates, we're not in a country where there's a high prevalence of TB. I should have done a gram stain of the sputum to see if there was any of the microbiology that causes the TB, which I didn't. By plan, I treated him as outpatient actually. He did have severe symptoms of worsening resting dyspnea, high respiratory rate, decreased oxygen saturation. He was cyanotic, and his initial medical management he wasn't responding to it anymore. He also had the arrhythmia. So I consider this an exacerbation of, I can't say that word, of a COPD, but he wasn't in acute respiratory distress. I also categorized him grade gold 2, group B, because of his FEV1 being between 50 and 79, and then having the current exacerbation in addition to the one he had 6 months ago where he went to his primary care provider. So for management, non-pharmacological, I told him to stop smoking. He technically doesn't need oxygen therapy, but I prescribed it just in case he feels like he needs it. I did want him checking his oxygen levels at home. I assessed his inhaler technique. He needed to get vaccinated for influenza, COVID, and pneumococcal vaccines, and then pulmonary rehab. For pharmacological, he does need a short-acting beta antagonist or SOB to treat the exacerbations. Example would be salbutamol, 4 to 8 puffs, Q, 20 minutes, up to 4 hours. And then also I was thinking a long-acting beta antagonist and the corticosteroids. But the Advair he was on wasn't working, so maybe we could try a different one. So maybe the formoterol buccinide, probably not saying it right, which would be 2 puffs inhaled twice a day. And then because he's having an acute exacerbation, Gold recommends that he get systemic corticosteroids for 5 to 7 days, and an antibiotic such as a macrolide for 5 to 7 days. And then if he needs oxygen, try to get it between 80 and 92%, but he's at 89, so he's kind of borderline there. Follow-up, I wanted him to come to the office in 1 to 2 weeks to see how he was doing on his medications. He needs yearly chest X-ray, spirometry, and EKGs. He would need to go to the ER if he experiences acute respiratory failure, which would mean his respiratory rate's over 30, acute changes in mental status, hypoxemia, not improved with supplemental oxygen. So what I should have done, I should have gram stained the sputum to rule out TB and see if he was having a bacterial infection in addition to all this, and if he needed antibiotics. I also need to do an arterial blood gas. I could have addressed other comorbidities that coexist with COPD, such as lung cancer, cardiovascular disease, osteoporosis, depression, anxiety, GERD. I also should have addressed his diet, encouraged him to consume high-protein, low-carb diet to prevent malnutrition, and then he does need routine ABGs and liver function tests yearly. So basically, I think that's it. Yeah. Thanks for listening.